Okay, good morning, everyone. I'm Captain Nate Nye. I'm a sports medicine physician down at Lackland Air Force Base at the basic training program. I appreciate Dr. Leggett inviting me to give this talk. It's a topic that I definitely feel passionate about, and it's something that we deal with on a day-to-day basis in the basic training environment. So I find these topics very fascinating, and there's definitely a lot that science has shown us and a lot that we have yet to learn. All right, so we'll get started. Today I'm going to talk about these exertional injuries, and I'm going to take this back to humans as endurance athletes and talk a little bit about the evolution and our evolutionary advantages with performance. We're going to go into then and talk about what a primary care provider should know about exertional heat stroke and exertional rhabdomyolysis. And at the end, we're going to tie in a little bit of information on sickle cell trait, which has definite relationships with these two conditions. So each of these topics could easily be an hour or more lecture. These are big topics, but we're going to hit the high points, and then I'll try to give you some information on what we're doing down at Lackland and some lessons learned from our end. Okay, so you may or may not be familiar with the book called Born to Run, but this is a book that really kicked off the barefoot running revolution and pointed out, really brought into the public limelight the awareness that humans really do have a lot of adaptations to run, and that humans have been running for millions of years. There's good evidence that humans were eating large land animals well before any evidence of bladed weapons were around, and the theory is that humans were running these animals to exhaustion, that basically they would track them over long distances and overheat them, and that these animals would collapse and suffer essentially a heat stroke, and that it would be easy to take the prey at that point. Humans are very well suited for running. We have a well-designed foot for shock absorption, balance, spring. We have a long Achilles tendon, which allows power output and elastic recoil. We also have a large and very fatigue-resistant, very injury-resistant gluteus maximus, which gives us that hip extension to propel us forward. So clearly, humans have biomechanical advantages for endurance running. We also are the most proficient land species on the planet in heat dissipation. We sweat better than any other animal, which is not surprising to some of us. We have very sparse hair or fur on our body, and it definitely allows for our human body to dissipate heat and tolerate, when trained, a prolonged exertional event where other animals cannot do the same. So what happens when we have this evolutionary advantage? Some of us train ourselves and we have a high level of fitness, some of us don't. We all experience, when we exercise, a sensation of fatigue. So what causes fatigue? What causes us to reach that point where we have to stop? The classic thinking is, I think, that most of us default to that it's the heart. My heart's not strong enough to pump that much blood, or my lungs can't get that much oxygen. It kind of feels that way, but that's really, science has not borne that out. If the pump were the limiter, we would see heart failure at the point of exhaustion. But that's not what we see. There's good evidence that really what we're experiencing is a central governor phenomenon, where the brain imposes the fatigue on our body, and it reduces the neuromuscular drive. And our brain essentially turns off our muscles and our metabolism as a protective mechanism, which is very interesting. We also know that multiple factors contribute to that brain exhaustion. Hyperthermia is a well-known contributor to that. When we exercise, clearly we generate metabolic heat. 10 to 15 times at the rate at rest, and that heat has to go somewhere. We have to dissipate it, but our core body temperature definitely rises, and as the hypothalamus senses the rising core body temperature, it triggers cooling mechanisms to occur. But the hyperthermia tells the brain eventually, as the temperature rises to about the level of 104, fatigue really takes over, and not many athletes are able to push through and exercise past 104 degrees just because the hyperthermia triggers that brain fatigue. Dehydration also contributes, and those two are definitely interrelated, because clearly hydration status is involved in our heat dissipation, as well as our cardiac output and so forth. Together, hyperthermia and dehydration cause more fatigue than either one alone. So very interesting concepts. Finally, electrolyte imbalance and depletion of energy stores do contribute to fatigue. So what happens when we push this envelope? Some of us are well-trained endurance athletes, and we are able to perform at a high level to a certain point. But then that fatigue sets in. What happens if we push that, though? What happens if we are in some kind of a competition or some kind of a high-stress scenario where perhaps we're being chased by some kind of an enemy, or perhaps it's the race of our life? Our brain has the ability to push through sometimes, and when we push through that protective fatigue, we may come into these severe illnesses that we're going to talk about today. So first being heat illness, second being rhabdomyolysis, and finally, those can lead to collapse and sudden death by a variety of mechanisms. We're going to go ahead and dive into the first topic of exertional heat stroke. What is heat stroke? Well, heat stroke is defined as an exertional elevation of our core body temperature, or hyperthermia, and that temperature set point is 104 degrees. Now that is associated, in a heat stroke, that is associated with organ system dysfunction. It's most commonly seen with CNS dysfunction. A lot of times the other organ systems come in later, but the CNS is really the first place where we see organ system dysfunction that is clinically apparent. So we have hyperthermia and encephalopathy, and that 104 comes from the general observation that for most athletes, fatigue takes over at that point, and athletes generally don't keep pushing. And that is where the body has shown us that we are safe under that level. Some athletes can push and have been found at high temperatures such as 107 without any symptoms, but that's the exception. That's rare. For most athletes, a true heat stroke is core temperature 104 or above with CNS function. Now we're talking about exertional heat stroke versus a classic heat stroke, which is that scenario where you typically, an elderly person is in their home with no air conditioning, or whatever the case may be. They are unable to dissipate the environmental heat that they are absorbing from their environment, versus an exertional heat stroke where the body itself is the source of heat. Epidemiology is on the rise. So in the military and in civilian, and despite all of the awareness and the mitigation measures, heat stroke continues to be a problem. In Air Force BMT, it's actually basic military training. There's only been about 2 to 3 cases in the last 8 years, but the caveat there is we're not checking rectal temperatures, at least yet. And I'll talk a little bit more about what we're doing to bring our diagnostic and treatment procedures up to the current standard of care. There's been a recent event that was likely sickle cell plus potential heat contribution, but really the Air Force does, in my opinion, do a great job at prevention. The U.S. Army has a high number of trainees coming through, and definitely a high intensity of training that they conduct with their entry-level and advanced soldiers. In 1980, they saw an incidence of 1.8 per 100,000 for heat stroke, and in 2001, clearly a significant rise, and 14.5 per 100,000, and the rate continues to climb. In over DOD, we're seeing about 300 to 400 cases per year of heat stroke, whereas we see upwards of 2,000 to 3,000 heat-related injuries per year, including heat exhaustion, probably higher than that when you include cramps, the exertional heat cramps, which oftentimes don't get reported. But clearly these are things that are out there that happen. They can happen in a high-intensity training environment. They can happen when a squadron goes out or a battalion goes out and trains at a high level with some kind of a competition. There are clearly a lot of military installations in hot and humid areas of the country. In fact, a lot of our training occurs in those types of areas. And then certainly we are sending our troops downrange into areas where ambient temperatures reach 120, 130. And we're expecting our troops to perform at high physical levels wearing incredible amounts of gear and body armor, which may actually impair their heat dissipation. So we're putting our troops into and expecting them to perform in high intensity situations. We should know about heat stroke. So clearly prevention is key. We must understand risk factors. Early identification is really what's going to save a life. High ambient temperature, so wet bulb globe temperature in excess of 82 degrees Fahrenheit is where the high risk zone occurs. Red or black flag conditions. Also, lack of acclimatization. Generally, these heat injuries occur early in the season or early in training. When somebody is moved from a moderate climate to a hot climate, or from a period of relative deconditioning into a situation where intense training is occurring. It can be climate or exercise acclimatization. Poor aerobic fitness is clearly a significant risk factor, and that goes back to the body's cardiovascular system and the ability to dissipate heat, as well as our metabolic tolerance to heat. Some individuals simply genetically are more susceptible. Others are better at mounting the heat shock protein protective mechanisms to strenuous or prolonged exertion, or worse yet, both strenuous and prolonged exertion in excess of an hour is clearly a risk factor. Obesity, sleep deprivation also disrupts our body's ability to thermoregulate. Personal and family history of heat illness, including malignant hyperthermia. So an athlete or soldier airman with a current febrile illness, they're already hyperthermic, and they haven't even started exerting themselves. So let's not put these personnel at risk. These people should not be exercising if they have a fever. Heavy equipment, clothing. We talked about these heavy body armor or ABUs, CUs can prevent our body from sweating or reduce that convection and evaporation that needs to happen. Finally, medications and supplements. This is something that we should definitely be aware of, and that multiple medications do increase the risk for heat stroke, including diuretics, which can put us in a state of dehydration. Blood pressure medications, ACE inhibitors, beta blockers can mess with our ability to vasodilate to the skin and regulate our blood flow and generate that skin to core temperature gradient that must be present for heat dissipation. Anticholinergics, antihistamines impair our sweating. Caffeine, stimulants, ADHD meds, a lot of over-the-counter stuff can impair our fatigue response and really, especially in these very driven personnel, a lot of times special ops guys or our bodybuilders that after duty hours they're going to the gym and pumping up the iron with a lot of supplements. that really put them in a state of central overdrive and energy. They feel pumped, and they ignore their protective fatigue response. Finally, there are medications that may alter our hypothalamic temperature set point, and there are going to be some drugs of abuse in there, perhaps some antidepressants as well. Again, multiple medications. So what about signs and symptoms of heat stroke? This is clearly something, combative, confusion, or coma. The 3 C's are what's classically described, but there are oftentimes a lot more than that. So what you're going to see out on the training pad or out on the race course is disorientation, perhaps somebody who's a little bit confused, saying things that don't really make sense, or maybe they're acting a little funny, a little off. Those are the early signs of CNS dysfunction. A lot of times people get agitated, very angry, perhaps being very vulgar, abnormally using a lot of 4-letter words. Things progress, and a lot of times we may see dysarthria, slurred speech. They look drunk. They're ataxic, cerebellar ataxia, staggering about. There may be a consciousness. Some people may simply get to the point where they collapse and they are unconscious. There may be, for a lot of athletes and warriors, there may be a lucid interval where their temperature actually rises above 104, and they tolerate it for a certain amount of time until they succumb, and they may quickly fall into profound encephalopathy and loss of consciousness, coma. So the classic hot, dry skin is really not something that we see in exertional heat stroke. It's definitely possible, but that's more a sign of classic heat stroke. So don't expect to diagnose a heat stroke. You should see the hot and dry. These people are sweat. They're sweaty. They've definitely exhausted their body's cooling mechanisms, and they're wet. Their skin may or may not be hot. The core temperature is what's hot, but they may have cool skin. But definitely a rectal temperature of 104 or greater is diagnostic in combination with CNS dysfunction. Has to be a core temperature, rectal temperature. Any other temperature source is completely unreliable because of that skin to core temperature gradient that the body sets up. So no axillary temperatures, no skin, no forehead, no temporal, no under the tongue. None of that stuff is worth even checking. It may actually mislead us if we deceive ourselves into thinking that 101 temporal temperature is a true temperature. It's really not a reflection of their core temperature. Treatment for heat stroke is something that's been well studied, and there is excellent evidence out there that ice water immersion is darn near, if not perfectly, 100% protective at preventing mortality. When this can be instituted within the first 15 minutes of identification of a heat stroke, so far there have been no fatalities when that's able to be implemented immediately and get the body temperature down. Ice water immersion is definitely been proven to be more rapid, more effective than any other cooling strategy, and it should be the first treatment that is undertaken. So in scenarios where high training intensity is occurring, these types of cooling apparatuses should be available. This is done in combination with continuous rectal temperature monitoring. You have about what we call the golden half hour until the mortality and morbidity really start to climb. The body's organ systems just do not tolerate prolonged hyperthermia. The cells' membranes begin to become weakened and rupture. The proteins denature, and the cells simply cannot function above 104 for very long. And you start to see heart failure, liver failure, kidney failure, and clearly encephalopathy, eventually death. So this is something that has been hammered out. If we cool them first and transport them second, these people are probably going to do well as long as we are able to recognize it on time. We'll talk about perhaps some cases later, but there are definite, really, what distinguishes a severe case of heat stroke from a mild case of heat stroke is the time that we take to get them into the ice bath. Really, we must get them into the ice as soon as possible. There are other, putting ice bags in the groin and the axilla. Ice sheets can be wrapped around the patient, but these really are just temporizing measures. They can start to get the temperature down, but they are not definitive. There is no definitive option other than ice water immersion. Again, we've talked about prevention, work rest cycles, acclimatization. 10 to 14 days is recommended as someone enters a new climate. Hydration is super important to maintain the body's ability to dissipate heat and maintain cardiac output. There are actually some interesting cooling mechanisms out there, some heat ice troughs that the Army is using in certain locations, such as Fort Benning, that do help to keep their troops cool. Some very interesting ideas out there. Return to duty is also an important topic. There's no accepted, validated, evidence-based guidelines out there. ACSM does currently recommend that for at least 7 days after the incident, that the patient does not exercise any further. They should follow up at least a week after the incident, should have repeat labs and perhaps any imaging that may be required to follow up on sequelae of the injury. They should begin exercising gradually and begin it in a cool environment. If unable to tolerate vigorous activity within 4 weeks, that is a point where you would want to consider a heat tolerance test. That would be a referral to Dr. O'Connor and his heat lab. He and his team of scientists do perform heat testing, and they have a heat chamber and various tools to figure out what are these, what is the underlying problem, and is this somebody that may be at risk for further events. And finally, if this individual is able to exercise progressively and is tolerating it from a heat standpoint, then we can return them to full duty at about 4 weeks after the injury if there is no other complications. Moving into exertional rhabdo. So we're going to change gears here just for a moment. We've talked about heat stroke and all of the metabolic complications when we're unable to dissipate that heat. So interestingly, heat itself may, as it causes membranes to destabilize and to rupture, the liver fails, the heart fails as the hyperthermia persists. Well, the muscle cells really don't tolerate it either. So those muscle cell membranes may rupture, and the protective proteins in the membrane start to denature, and the membranes just are become incompetent and rupture. You actually get rhabdo as a result of heat stroke. But you may get exertional rhabdo simply from overexertion or perhaps an underlying condition. So we'll talk about that. What is the definition of exertional rhabdo? Well, it's myonecrosis. It's spillage of myocyte contents into the circulation. It's a spectrum injury. There is no physiologic moment where somebody is normal and then they become abnormal. There is certainly a spectrum from asymptomatic CK elevation to symptomatic CK elevation, and finally cases of fulminant myonecrosis with associated acute compartment syndrome, hyperkalemia, arrhythmias, which can lead to renal failure and death, can be, again, very severe. So how does this happen? Excessive, prolonged, repetitive exercise, particularly unaccustomed exercise. This is a classic story of a new commander who wants to whip his troops into shape and takes everybody out and does burpees till they drop. But just the repeated single exercise overwhelms the muscles and causes them to break down. So eccentric exercise is also known to be particularly problematic for the muscle over a prolonged period. Other factors that contribute include dehydration, heat illness, as we've talked about, sickle cell trait, as we will talk about, definitely increases risk for rhabdo. Medications such as statins, diuretics do put the individual at increased risk. And supplements such as caffeine, ephedra, JAK3D, NO-Explode may allow this person to push that fatigue, that protective fatigue mechanism, and go to the point of muscle breakdown or heat illness. Finally, and importantly, exercise may unmask underlying pathologies. So it simply may be the last straw that broke the camel's back, as an individual, perhaps a basic trainee who has not done much physical exertion in their lifetime, and they come to basic training, start to run, and they experience muscle pain, weakness, are diagnosed with rhabdo, and really maybe actually somebody who has a muscle disorder. So we see high levels of CK in exertional rhabdo. What is CK? So CK is simply an enzyme that's part of the phosphagen energy system that turns our phosphocreatine, splits off the phosphate, gives it to the ATP, and generates creatine. So it generates an ATP molecule. It's very rapid energy production. It's present in all of our muscles. Simply, it's a marker. In terms of exertional rhabdo, it's simply a serum marker. CK is not doing any damage itself. It's the myoglobin that does the damage to the kidneys. We see high levels of it, and it is found to be a good indicator of the degree and extent of muscle breakdown. It's also hyperkalemia, which is what causes the arrhythmias. That's really what can kill you. There's been some interesting studies performed in the basic training environment. We found that on day 3 through 7, most of our trainees have an elevated CK, and in fact, many of them are well within the definition of exertional rhabdo, which is the 5 times the upper limit of normal with the CK values. So with the history, when we see these patients in clinic, they report a history of intense, unaccustomed exercise. And approximately 24, 36 hours later is where the severe muscle pain and tenderness sets in. They're weak, they're very stiff, and they report dark, cola-colored urine. CK levels are often in excess of 100,000. Some of the fatalities that have been reported had CK values of 3 million or more. So when we see values of 3,000, it sounds really high. Oh, 3,000, it's much higher than some of the other lab numbers that we talk about. Several thousand really isn't a whole lot. We get over to 50,000, then 50 to 100 or more, 100,000, then it's when we're talking more severe rhabdo. This is from a recently published article that was written by Dr. Shepanik, who was one of the fellows who trained with me last year in fellowship. She wrote this excellent article along with Dr. O'Connor, who's really the expert on rhabdo and heat, and probably should be giving this talk. So this is an excellent article that's out there. I'll cite it at the end. But the definition of rhabdo should be considered when symptoms of muscle soreness, stiffness, and weakness are out of proportion to the level of exercise performed, and there is laboratory evidence of myonecrosis. And this article is proposing a definition of 5 times the upper limit of normal, which is about 200. Certainly, the normal values may vary based on sex, based on age, based on gender, so based on nationality as well. African Americans have been shown to have higher baseline levels of CK compared to non-African Americans. The classic triad: muscle soreness, weakness, dark urine, out of proportion, pain out of proportion, along with laboratory evidence of myonecrosis, are the triad that is required to diagnose. So we don't generally need to check a CK unless you are clinically concerned for exertional rhabdo, and what would trigger that concern is that clinical triad: weakness, soreness, stiffness, and pain, tenderness out of proportion. So what labs should you get when you suspect this? Well, we start with urine and blood. We check a simple urinalysis with microscopy. A lot of times we see heme-positive urine, but no RBCs on the microscopy, and that is the myoglobin that's triggering the heme. Urine microscopy. Hypocalcemia is oftentimes present. Hyperphosphatemia are often present in addition to the hyperkalemia. A lot of times we see an anion gap metabolic acidosis. So basic metabolic panel, UA, CK. There's no need in most cases for a comprehensive metabolic panel. You just need the potassium, the creatinine to check their kidney function, and you need the other electrolytes. But generally, the liver is not what we're worried about. And in severe cases, get a baseline EKG may be a consideration. Treatment of exertional rhabdo clearly will consist of rest and hydration. Now, that may be PO hydration or IV. It may be inpatient or outpatient treatment. There's no accepted cutoff for when the person should be admitted. So admitting for IV fluids when the CK is greater than 5,000 would be a very conservative and perhaps overly cautious set point. There are certainly many cases and precedent for outpatient management of these types of individuals. This is a clinical decision that the provider must make on a case-by-case basis based on their concern for arrhythmias, noncompliance, compartment syndrome, or complications from the rhabdo that may be present and prevented by admission to the hospital, and certainly the acute renal failure that may ensue. If there's a bump in the creatinine in excess of 0.5, you may consider IV hydration on an inpatient basis. There's no discharge criteria either. There's been some interesting studies, when it is safe to discharge, but many times people who are comfortable managing rhabdomyolysis will hydrate the patient until the lab values have clearly established a downward trend, and the creatinine, kidney function has returned to near normal, probably within 0.2, 0.3 of their normal values. The muscle soreness tends to resolve over about 1 to 2 weeks, sometimes a little longer. CK peaks at about the 48-hour to 96-hour mark, generally about 3 days in. And the myoglobinuria resolves in a couple of days, as long as the exertion is stopped. There are a number of high-risk criteria, and we'll wrap this up with this discussion before we move into sickle cell trait. What are the high-risk criteria? When should we worry about somebody having perhaps an underlying disorder and risk of recurrent rhabdo? It's an oddball case. Perhaps it's somebody who has a delayed recovery, more than a week, despite restriction of activity. Perhaps it's somebody who had a persistent elevation of CK above 5 times the upper limit of normal. Perhaps it's somebody who had acute kidney injury that does not return to baseline, or an episode of rhabdo that occurred after only mild or moderate exertion. Personal and family history of metabolic myopathies or rhabdomyolysis. Or perhaps it is simply somebody who has a overwhelming CK response over 100,000, and we want to take a closer look at those individuals. Certainly, anybody who has a CK over 100,000 should be further worked up for an underlying disorder. So here is an algorithm that is suggested in that article by Dr. Shapanik and Dr. O'Connor. I think this is an excellent guideline. Again, we start with a history and physical labs. We look at those high-risk criteria from the previous slide, and if any of those high-risk criteria, the oddball case, are present, then we would like to send that patient to a neuromuscular specialist. Consider an exercise intolerance panel, and that would be something that I would perform in consultation with an expert, such as Dr. O'Connor or a neuromuscular specialist, somebody from CHAP. Get in touch with these experts, these resources who handle these things on a regular basis and can perform and interpret those tests with us. So when we perform that high-risk workup and we see some interesting findings, then we refer or further workup as indicated. or we reassure the patient and allow them to return to training or return to play. So a couple of interesting cases. We'll just hit a couple of highlights with these. 19-year-old Caucasian male, lightheadedness on his 0 week of training or initial fitness test. He's got muscle soreness. He comes to the clinic and he's sore. He's tells the doc that he was lightheaded, and somebody who's perhaps unfamiliar with rhabdo just hears the soreness and rhabdo crosses their mind, so they check a CK despite the lack of severe pain or tenderness out of proportion. They get a CK that, yeah, it's a little bit, it's 5 times the upper limit of normal. Okay, good enough. So how about a 21-year-old Egyptian male with severe muscle pain? One day after an intense repetitive training session, severe pain, CK 50,000, and cola-colored urine. These are certainly 2 different cases. The first one I would call a very mild rhabdo, not even, this is more of a delayed onset muscle soreness type of a scenario. Now, this 21-year-old Egyptian male is clearly somebody with exertional rhabdo, and this gentleman, in a real case described in some of these papers, but had a normal recovery in 2 weeks, and then was found to have recurrent rhabdo with progressively lighter exertion, and was worked up for some of these high-risk conditions. This person was boarded out of the military. Let's move into sickle cell trait. This is a very interesting condition and a topic for discussion in certainly in the sports worlds as well as in the military. The military does screen, at least the Army. The Air Force, Navy, and Marine Corps are screening on a universal basis. The Army has a different approach. The Army has had great success with simply implementing universal precautions with work rest cycles and ambient temperature monitoring and solid, good hydration practices. So definitely 2 approaches there. The Army is evaluating their policy. They're considering moving to a universal screening policy in accordance with the other sister services. But we'll see. It's an interesting topic. Definitely a lot still to be figured out on how to do this the right way. Sickle cell trait is a condition where the individual has 1 normal hemoglobin gene and 1 sickle hemoglobin gene. And this condition places them at increased risk for exertional collapse, which we call ECAS, or exertional collapse associated with sickle trait. It does place the individual at definite increased risk for sudden death. However, this is a relative risk, and it's still an extremely rare event. In fact, the NCAA studies have shown that collegiate athletes are more likely to die from a lightning strike than from sickle cell trait. However, it is certainly out there and definitely does increase the risk for heat illness and for rhabdo. So it is prevalent in 8% of African Americans, 0.05% of Caucasians. Now, those numbers are, simply from somewhat small population studies, and genes are mixed and mingled and all over the place, and you never really know what somebody's genetic inheritance is really going to be. So focusing, for example, on African Americans is not an effective policy. So what are the risk factors for this exertional collapse, and how do we prevent it? Certainly hydration is key. Hydration status does affect the stability of those RBC membranes. And as the blood becomes more viscous, as plasma volume goes down, the rheology shows that those RBCs will start to sickle and may cause those occlusive crises. Exertion in the heat does definitely increase the risk for sickling. However, this is a point of contention. Some people feel that heat is a significant factor, while other experts in the area feel that it is really not the issue, where rather they would argue that it is the intensity of the exercise, not so much the heat. regardless, these are individuals that when the sickling starts to happen, it sets up a vasoocclusion with downstream ischemia with acidosis and membrane rupture, at times massive hyperkalemia, potassium spillage, which may cause arrhythmias and death. Now that's what scientists hypothesize is happening. It's never been validated, and it's very difficult to validate because when somebody becomes anoxic, everything sickles. And so there's no pathonym autopsy finding that tells you that this death, this collapse was from sickle cell trait or from sickling. The issue of to screen or not to screen is a big area of debate again, as the Army has shown us that if you simply have universal precautions and you train wisely, that you can prevent a lot of these events. The NCAA has a policy of screening, and some argue that that is saving lives. The counter argument is that it's not a perfect screening test. No test is perfect. You do miss some cases of sickle cell trait with the screening test, and so you may miss the person who is sickle cell trait positive is going to collapse. Definitely a point of contention. There's a lot that we don't know. There's a lot of research that is underway and is moving forward. Dr. O'Connor and Champ are going to be collaborating with us at Lackland on a study that will look at what genes may travel with the hemoglobin S variant that may make a sickle cell trait individual more at risk for exertional collapse. There are in excess of 1,100 known hemoglobin gene mutations, and so certainly it's not a homogeneous or a simple gene mutation. There's probably multiple variants of what we call sickle cell trait positive. It's probably not all sickle cell trait positive patients being the same. Other interesting questions include what portion of exertional heat stroke related deaths in military recruits is independently a result of sickle cell trait. So heat and sickling, what's the relationship? How does heat contribute to these supposed sickle cell trait deaths? Does the risk of serious complications from heat illness among recruits with sickle cell trait positively correlate with the degree with hypocynuria or inability to concentrate the urine? Do sickle cell trait or exertional heat stroke deaths, are they inadvertently attributed to cardiac abnormalities or vice versa? Again, it's very hard to retrospectively identify a collapse as sickle cell trait. We do know whether they're positive or negative in many cases, but hard to label these cases. At Lackland, we are working on implementing policies to place heat stroke treatment stations, these ice bath stations in strategic locations around the training environment, both in basic training and in advanced technical training with our special ops, pararescue, combat controllers schools, as well as our security forces training school, where these personnel are doing high-intensity rucking, marching, night land nav, various high-risk training scenarios around the San Antonio area. And currently, we do not have any rectal temperature equipment in place. So we've got a massive, in my opinion, it's a heck of a lot of work to procure all of the equipment, to train the leadership, the instructors, the paramedics, the IDMTs or corpsmen, to brief the commanders, update the local OIs, operating instructions, and write new operating instructions to implement these policies, procedures. And this is a massive undertaking to really treat these potential heat strokes in the right way. But we are doing that, and very soon we will have here at Lackland the ability to immerse our trainees with heat stroke in ice water with an accurate diagnosis based on a rectal temperature in a matter of minutes. So we're proud of the work that we're doing, and we do salute our colleagues in the Army and Navy who are already doing this and have been doing it for a long time. We'll summarize with some take-home points. Again, we've talked about heat stroke, we've talked about exertional rhabdo, and we've talked a little bit about sickle cell trait. Again, all of these topics are huge, they're interrelated, and they are all related to exertion, and these are things that may cause significant injury and even death among our troops who are performing high intensity training. Early identification of these conditions, particularly heat stroke, is critical, maybe life-saving. Really the point that will determine severe or a mild case. We've got to get those patients in ice immediately within ideally 5 to 10 minutes, hopefully no longer than 15. But if you've got to transport that patient more than 20, 30 minutes, well, you're really putting that patient at risk for death. We must understand the role of risk factors for heat illness, for rhabdomyolysis. With rhabdo, we treat the patient, not the lab value. We need to understand the clinical syndrome, have the mindset of preventing those bad patient outcomes. So identifying those high-risk personnel who may have, the next time they go out may be their last. Those are the kind of cases that we may want to further evaluate and consider boarding out of the military if they have an underlying metabolic disorder. So, and finally, keeping in mind the sickle cell trait, while very common, may raise the risk for exertional rhabdo and sudden death, even though this is a rare event. So with that, I will refer you to a couple of really good articles, the one by Dr. Shapanic, Dr. O'Connor, and there's a very good article, the ACSM Position Stand, authored in part by Dr. Casa from Horst Junior Institute. Finally, just a hats off, a nod to Dr. O'Connor, Dr. Butler, for the excellent training and the lectures that we got during fellowship last year. These were excellent resources for me in preparing for this talk. So I would definitely refer everyone to the Human Performance Resource Center website at hprc-online.org. I will refer you to the Physical Fitness tab on that site. Once you get to the Physical Fitness tab, if you scroll to the bottom, there is a button called Rx3, Rehab, Refit, Return to Duty. Once you go to that link, you'll see multiple options, including for the warfighter, frequently asked questions, and then you'll see a button called For the Provider, and that's where I would refer all of us to go for resources on diagnosing and treating these exertional injuries and understanding how to tap into these expert resources that we have in Washington, D.C.